I think it's important to consider that MRD meet the key requirement to be an endpoint for survival and treatment monitoring. And the reasons is because supersede CR is more potent than CR to predict survival, predict in newly diagnosed transplant and non-transplant eligible patient, as well as in relapsed patients, has been confirmed by two different techniques, NGS and NGF, across the world in many different labs, predict the outcome upon different MRD rates. In other words, the lowest the level of residual disease, the longest the survival. 10 to the minus 6 is better than 10 to the minus 5, minus 4, minus 3. It has impact both in standard and in high-risk patients to predict outcome. And on top of this is relatively cheap technique if you compare with the cost of any treatment. And this, the reason for this is because you can use this technique to try to adapt the treatment. In other words, for treatment monitoring. That was exactly your question. I mean, if I'm convinced you that MRD is the most relevant parameter for prognostication and to evaluate response to therapy, why not to use to drive therapy? And the potential uses are, first of all, to compare two treatment approaches. You compare one quadruplet versus a triplet, and you can see that the quadruplet is superior to the triplet in terms of progression-free survival. And you ask why? And it's because of the depth of response. There is a very beautiful correlation between the MRD rate achieved by the quadruplet higher than with the triplet, and this translates into longer progression-free survival. In other words, you can compare early on which one of the two approaches is more efficient, CAR-T versus transplant, for instance. Second, to adapt treatment therapy according to the MRD follow-up. And you have already the MIDAS trial, in which you have also the UK Humara trial, in which they stratify the patients not according to cytogenetics, but according to the MRD. And they consider, in the MIDAS trial, a standard risk, the patient that achieve MRD negativity, and high risk, the MRD positivity. And in the negative ones, they have compared to continue the same treatment with a quadruplet versus one transplant. And the MRD positive patients, they are comparing 1 versus 2 transplant. In other words, you can adapt therapy according to the MRD. On top of this, you can adapt the duration of treatment and the intensity during the maintenance. And there are plenty of evidence coming from Chenogostram, Bio Group, and several ones in which we have decided to stop maintenance at a time that is the patient has been on sustained MRD negativity for a period of more than 2 years, providing that the patient was not high risk, or they also providing that the patient achieved the MRD negative rate very early on the treatment, after induction or after transplant. In other words, you can use the MRD to try to adapt the duration of maintenance. Also, another possibility in terms of practical use is to introduce early rescue intervention. Nowadays, we treat our patients as soon as they develop biochemical relapse. We don't wait until the patient has a new fracture or renal insufficiency. As soon as the patient has a biochemical relapse, we treat immediately. Why not to treat as soon as the patient has an MRD conversion? Okay. And last but not least, to adapt therapy in our current clinical practice. In my current clinical practice, outside of clinical trials, when I have a patient that has persistent MRD negative MRD positivity after the autologous transplant, I try to modify the consolidation in order to eradicate the treatment. Last but not least, although my goal is to achieve MRD negativity, my driver is MRD positivity. In my current practice, the decisions that I take is usually based on the MRD positivity. When it's positive, I change the treatment.